Okay, I'm going to go ahead and start off by welcoming everybody to functional webinars. So I would like to start off today's webinar. Again, my name is Kathleen Steele. I will be moderating the session, and I'd like to start it off with the quote. You can't go back and change the beginning, but you can start where you are and change the ending. We would like to thank you for being part of our wellness community, and we realize that despite your busy schedule, you've opted to join us and participate in this webinar to help yourself, your family, and your community to live healthier lives. Last webinar, we discussed how how exposure to mercury leads to chronic diseases. If you missed it, you can view it in the video library, or you can catch it on YouTube. Please subscribe to our YouTube channel for previous functional webinars, as well as if you want to receive notifications for future webinars. Today that we ask that you please keep your microphones on mute, and that all questions and answers that come up, we ask that you type them in the question and answer section rather than the chat section to make it easier for us to go ahead and answer as many as we can. So further ado, today's topic, how to balance your hormones naturally. So I would like to start off by introducing Dr. Nadia Ali. She is the founder of Functional Integrative Medicine Practice, Functional Holistic Healing. She's been practicing for 16 years. She's board certified in internal medicine specialty, board certified in integrative medicine. She's a fellow of the American College of Physicians, a member of the Institute of Functional Medicine, and she has certifications in the area of nutrition, mind-body, Ayurveda, and Chinese medicine. You can learn more about her practice at www.theholistic.healing.org.
Thank you, Kathleen. And what I would like to do today is to introduce our moderator. So you may have seen Kathleen moderating the functional webinar since they have started, but most of you don't know that Kathleen is also, in addition to being interested in functional medicine, has been somebody who is a counselor. She actually did her master's in education with a specialization in counseling. She is a member of the Chi Sigma Iota National Counseling Honor Society. She is a member of the American Counseling Association. She is a national board certified counselor. In addition, she's a licensed mental health professional counselor. And the reason why I'm introducing Kathleen to you is because her journey into functional medicine actually started like my journey through her own personal experience. And the primary issue that she encountered was directly related to hormonal imbalance. And that is why we are here today to know about her story. So I'm going to go ahead and ask Kathleen to tell us her story.
Thank you so much. So my story started around 16 when I started having regular menstrual cycles, and they were actually pretty irregular. I would have extremely heavy periods where I was getting like episodes of blacking out. The migraines before actually when my cycle would start, I would, especially in school, like when the fluorescent lights, I'd have to go to the nurse's office, and the nurse, of course, would console me and hand me some ibuprofen and allow me to go sit in a dark closet. But you start missing, days of school, and you start taking more and more ibuprofen, and it started leading to more symptoms. So I ended up going to multiple GYNs, and I went to some primary care physicians, and everybody was saying, oh, this is normal. It's normal to have painful periods. It's just a bad period. It'll get better as you get more regular. It'll get better as you get older. It didn't, it got worse. So then I went to different GYNs who were not listening to me. And I finally found one that heard me and suspected and kind of mentioned endo, but there wasn't anything more they could do about it. So he just kind of said, okay, well, it sounds like you might have endo. Let's at least do pain management and let's see if we can treat it. So they treated me by offering me birth control, which was the combined pill, estrogen and progesterone. That caused mood swings, weight gain, and it wasn't just like a little bit, and tons of bloating. I was also still having to take tramadol or and I was on top of ibuprofen while on birth control to manage the pain. And finally, I ended up using narcotics to manage my pain when I was off of the birth control and trying different ones. And I actually had tried the last hormone contraceptive that I was trying. I had tried the progesterone only as well. The last one I tried was the NuvaRing, and it was a bad side reactions with like rashes and things. So I ended up going for a laparoscopy because I was told that if I was diagnosed with endometriosis by an urgent care physician and another primary care, if I was diagnosed, then they could treat me and they could at least manage my pain because they had said that they can't treat me anymore with pain management so unless I have an actual diagnosis. So I went under laparoscopic surgery to get diagnosed, which led to more intense scars, more than a laparoscopy procedure, and a lot of post-op complications. After I came back from that, when I was going back, because I was having more pain now, even though it was supposed to help my pain, this laparoscopic surgery. They offered me a hysterectomy. That was one of the first things they had offered me after I had been given different things. And one of the last straws was the hysterectomy and the Lupron. And I just realized that I knew at that time of my life that I was in my early 20s, I might want a family, and pretty soon, especially with endo. So I was like, okay, I just want to be off all medications and I want to figure this out so I can show up for work, do what I need to do, and kind of get my life back in order. So I wanted to find that root cause rather than just taking something. So I was blessed and I was able to start working with Dr. Nadia Ali. I am currently using IV support, supplements, and the infrared cocoon, which has done wonders for detoxing and helping cysts and things flush out of my system. My pain has improved. My daily pain has improved tremendously. My bowels have improved a great deal. And I had a 4.5 centimeter cyst endometrioma, which they had told me through MRI. And when I went back in to get it checked out, they couldn't find it. There was some fluid, but they couldn't find it. So I was really happy about that. And my energy seems to keep improving as I'm on this healing journey. And I'm excited to see where it brings me. So that's my story. And if anything, at the end of this, I have 2 resources, and there's one that I wanted to mention, which was Endo What, and it's actually a school initiative, and part of my school counseling, I have to put a plug in, is they give a kit to a school nurse to help identify endometriosis, so that way when students have to ask teachers, for pain, they don't get their eyes rolled, and school nurses are able to better identify and better help with early intervention rather than having to wait. So that's kind of the resources that I found very helpful. So I'd like to start off by asking because I've been talking to a lot of other women, and they all seem to have bad periods too, but again, they think it's normal because they've been told it's normal. So the first question I want to start with is, what does a normal cycle look like? And is there supposed to be ovulation pain? And I also want to know, why is it so difficult to diagnose hormone disorders?
So that's an excellent question. So it is true that a lot of women actually have some kind of PMS symptoms. Almost 80% of women have some kind of PMS symptoms. However, when the symptoms become severe or moderate in nature, the symptoms become debilitating, making it difficult for you to study, making it difficult for you to work, making it difficult for you to do day-to-day activities, then that is abnormal. That is an indication of hormonal imbalance. If you're losing so much blood that you're having iron deficiency, that is abnormal. If you're having major nausea, vomiting, you're wasting multiple days in a month simply because of hormonal issues or periods, that is abnormal. If you have mood swings which are making it difficult for you to continue to work, or it's making it difficult for you to stay in a relationship, that is abnormal. That is not acceptable. If you look at this chart, I think this is an interesting chart. If you see, this is normal when you have blood and it's like bright red in color. But if you start having clots or stringy stuff coming out, or it's gritty, or the color of the blood is darker, gray, or black, those are signs that you are bleeding much more than usual. But this is not enough to diagnose moderate to severe PMS. You also have to have, like I said, symptoms which are moderate and severe. As far as ovulation pain is concerned, some women do have a small degree of pain when they're ovulating. But the other woman who would say that the time of ovulation is very difficult for them because they have a lot of pain. Or they would say that at the time they have severe mood swings, they have food cravings, that is definitely an indication of hormonal imbalance. And if you are having those symptoms, and this is also true of women who are in menopause, because menopause is not supposed to be some kind of a curse for women. The idea is that in menopause, you are closing your reproductive system because you don't need it anymore. So one should not have to deal with unbearable hot flashes, or you are having significant weight gain, or you are having brain fog. That is abnormal. That is something that needs to be looked at. That is something that needs to be taken care of. As far as the question is concerned as to, why is it difficult to diagnose, it is true that a lot of women do go undiagnosed for a very long period of time. We often see women who come with other issues, and when we take their period history, and they tell us, oh, I bleed for 10 days, or I have always been anemic, and they put it as if it's completely normal because that's the pattern that they've had. We often have to tell them that is not normal, and they're surprised because they have never been told that that's abnormal, or that something can be done about it, or that something should be done about it. There are multiple reasons for that. The first reason being that when I will go through some of the common diagnoses, you will see that the symptoms in those diagnoses are pretty similar. So simply on the clinical ground, it is difficult to say whether you have PMS, or do you have polycystic ovary disease, or do you have fibroids, or do you have endometriosis. So symptoms themselves are non-specific and harder to kind of put a patient into a particular category. The second issue is that we don't have the best assessment tools, which means, for example, if you have high cholesterol, there is a particular test, you do the test, you see your numbers, and somebody can tell you, oh, well, you have high cholesterol, or they can tell you that you have high blood sugars. That is not the case with hormonal diagnosis. There is no particular test which can tell us that, yes, definitely this is endometriosis, or yes, this is PCOS. We have some tests, but they're not 100%. They do not tell us with certainty that that's the diagnosis. That's the second limitation. And the third and very important limitation is that when we talk about hormones like estrogen, progesterone, testosterone, we are often looking at reproductive organs. We're often talking about breasts or ovaries or uterus, or testes or prostate, but the implications of hormonal imbalance are much more than that. So if you look at this diagram, you will see that these hormones affect almost every single system in the body. For example, you can actually have memory loss or brain fog related to hormonal imbalance. You could have migraines. We now know that women with lack of estrogen may actually experience hearing loss. We know you could have hair changes, there could be hair loss, there could be skin changes like wrinkles when you don't have adequate hormones. Pituitary gland, which is the master gland inside our brain, is directly affected by estrogen, progesterone, and testosterone. We have estrogen, progesterone, and testosterone receptors throughout our body. We can actually have heart disease linked to hormonal imbalance. We can have gallstones related to estrogen. We now know that estrogen plays a very important role in sustaining good bacteria in our gut. So when you have hormonal imbalance, you are going to have gut issues. We now also know that estrogen has a protective effect on the colon. So adequate estrogen actually protects us against colon cancer. We know that estrogen, progesterone, testosterone play a very important role in the immune system. And that is the reason why autoimmune diseases could be an outcome of hormonal imbalance. Similarly, when we talk about adipose tissue or fat tissue, when we say that somebody has weight gain or somebody is obese, that can be a result of hormonal imbalance. And so if somebody has obesity and they go to a primary care physician, they're often told, well, you take care of your diet and exercise, but that may not be the reason why they have gained weight. They might already be eating better and they might already be exercising and still may not lose weight. If somebody has migraine and they go and they say, well, I have migraine, most of the time we give them a medication. We don't ask the question as to, could this migraine be hormonal in nature? Because if it is hormonal in nature, then instead of giving you pills for addressing migraine, we should address the underlying hormonal imbalance. We know that hormones play a very important role in bones. So you can see that osteoporosis is a consequence of that. You can have a recession of the gums and other changes because of hormonal imbalance. Similarly, there could be loss of muscle mass due to hormonal imbalance. So because hormones affect every single part of our body, that is why a lot of times when we have symptoms linked to non-reproductive areas, nobody asks the question whether this is hormonal imbalance. And that is why we often miss the diagnosis of hormonal imbalance, because we don't consider the whole person and we don't look at the root causes. And that is the reason why we often miss this diagnosis.
So I've suffered from PCOS and endometriosis. What are some of the common hormonal imbalances that are experienced by women?
So the first one we have talked about is PMS. And although 80% of the women do have PMS, about 30 to 40% of women actually have moderate to severe symptoms of PMS, premenstrual syndrome, which they experience around periods. And they could start a week before period and would end a few days after completion of the period. There could be emotional symptoms like tension or anxiety, crying spells, mood swings, depression, irritability or anger, changes in libido. There could be food cravings. There could be appetite changes, difficulty falling asleep, as well as social withdrawal. There could be physical symptoms like muscle pain, joint pain, fatigue. There could be gut symptoms like abdominal bloating, constipation, diarrhea. There could be breast tenderness, headaches or migraines, weight gain, fluid retention, acne, and brain fog. Now, remember that when someone has PMS, we often say, oh, what's the big deal? But it is a big deal. The reason why it is a big deal is because PMS actually increases the risk of ovarian cancer, particularly in women who have moderate to severe PMS. And so if you have a hormonal imbalance, you will have consequences of that hormonal imbalance, particularly if that hormonal imbalance continues for a long period of time. And hence, if you have moderate to severe hormonal imbalance symptoms, you should really seek help and understand why that is happening. The second disorder, which is quite common, is premenstrual dysphoric disorder, or PMDD. This is a severe form of PMS, which particularly affects the mental health. Basically, in this disorder, women experience extreme degree of mood shifts, and they would literally turn into someone completely different. They may have very little control over their own mood, and they wouldn't know why they are behaving the way they are behaving. And these women would tell you how their relationships are often affected by it, because they have such extreme degree of sadness or hopelessness, or they're so angry and they're so upset that they are not able to function, and it affects their work, it affects their home, it affects their children. The next one is polycystic ovary disease. So in this disease, basically the ovaries develop many more follicles than normal. And usually when we develop follicles, these follicles open up and then they release eggs. But in these women, even though they have a lot of follicles, not all follicles release eggs. So the symptoms in this situation is you find these women have irregular periods, they have excess hair, because we have found that these women have high testosterone. So they would have hair on face, chin, and other parts of the body. They would have thinning of the hair or hair loss on the scalp. These women also notice often darkening of the skin, particularly along the neck creases on the back, in the groin area, underneath their breasts. They have skin tags, they have weight gain issues, they have acne. Interestingly, one of the theory that is out there is that whether PCOS is a hormonal disorder only, or is it actually a metabolic disorder which is leading to hormonal disorder. And the reason why that theory is there is because these women also have a very high risk of developing diabetes, high blood pressure, and high cholesterol. And so the question is whether these metabolic changes are what lead to hormonal changes. And the hormonal changes we see is that these women have difficulty conceiving. They have multiple ovarian cysts and anovulation. That's why they have irregular periods. They have eating disorder. They may often also have sleep apnea. They may have depression and anxiety. And these women are at high risk for endometrial cancer. The next one is endometriosis. This is what Kathleen was alluding to. And if you see here, this is the uterus. It's the lining of the uterus which is supposed to change on a monthly basis. So we build that lining up, and if there is no pregnancy, then that lining is shed off. But imagine if this tissue is also present outside the uterus. It's present on the ovaries, it's present inside the pelvis. It can also be present on the bowels. And this tissue is referred to as endometrial implants. So what happens is that when hormonal changes happen, they not only happen inside the uterus, they actually happen throughout the pelvic cavity. It's also happening on the bowels. And the result of these implants is that these women have extremely painful periods. They have pain in lower abdomen, they have cramps, and a lot of times these changes would last literally 2 weeks before the period and during the period. So imagine somebody who has pain and cramps for 3 weeks in a month. I mean, clearly that woman cannot function. Of course, they have heavy bleeding, they have pain during intercourse, they have lower back pain. They also have discomfort with bowel movements. They have nausea, constipation, bloating. There could be fainting and lethargy because of all the bleeding that's going on. Chronic fatigue is something else that these women experience, as well as infertility. These women are at actually increased risk of ovarian and endometrial cancers. Last but not least is the next diagnosis, which is fibroids. So fibroids are basically abnormal growths. You can see these growths. This is actually right underneath the lining of the uterus. This is called serosine, or this is called subserosal fibroid, or they could be right inside the uterus like this one, which we call pedunculated because it's actually hanging by this area, so it's called pedunculated fibroid. So when you have these abnormal growths, these women would have heavy or prolonged periods. They might have bleeding between periods. They may have pelvic pain and pressure, frequent urination. They may also have back pain, bloating and constipation. They may have fatigue. They may have infertility issues, anemia issues, and pain during intercourse. So as you can see, as you're going through the different disorders, a lot of them actually have the same symptoms. So there are a lot of common symptoms, which makes it difficult to diagnose them on a clinical ground. Even though these are specific diagnoses, there are many other outcomes of hormonal imbalances. For example, and before we go there, just on fibroids, fibroids actually increase the risk of endometrial cancer as well. So here are the other outcomes of hormonal imbalance: breast cancer, breast cyst, and dense breast, endometrial cancer, ovarian cancer. Clearly, hormonal imbalance can lead to Alzheimer's disease or dementia, osteoporosis, loss of muscle mass, infertility, obesity, diabetes, high cholesterol, migraines, autoimmune diseases, high blood pressure, hair loss, and anemia are all outcomes of hormonal imbalance.
So we talked about the different diagnoses and conditions that are a result of hormone imbalances. What hormones are primarily responsible for this hormonal imbalance?
So a lot of times when we are thinking of hormonal imbalance, we are only thinking about estrogen, progesterone, and testosterone. But that's actually not the complete picture. Because remember that estrogen, testosterone, and progesterone are actually under the influence of other hormones. And two of the key hormones are cortisol and thyroid hormones. However, there is also influence of prolactin. There is also influence of aldosterone. So I want you to think of all of these hormones as a group of people who are dancing on stage. So imagine if one of the dancers falls, it affects every single one of them. And so when you are thinking about hormonal imbalance, you should not just think of estrogen, progesterone, and testosterone. You should think of all the other hormones because they're all interconnected. And sometimes the abnormalities of estrogen, progesterone, and testosterone are simply an outcome of the other hormones being in imbalance. So the problem is not estrogen, progesterone, and testosterone, but they are being influenced by the other hormones. Similarly, estrogen, progesterone, and testosterone can also influence other hormones. So you have to look at the bigger picture when you're looking at hormonal imbalance. The second thing which is very important to understand is that hormones are not in isolation. They are also affected by other factors. And the other factors that affect them are toxins, particularly xenoestrogens, inflammation, very important player, leaky gut, and nutritional deficiencies. So all of these four factors can directly affect many different hormones in the body. So when you're looking into hormonal imbalance, not only do you need to consider all the hormones, but you have to consider other factors which also directly influence the hormones.
You mentioned inflammation and leaky gut as drivers of hormonal imbalance. How are these connected?
So what is leaky gut? So I'm going to just give you a one-liner on that. We have a webinar on leaky gut, and if you're interested, I would ask you to go to our website and go to the, there's a video library that you can go to and listen to this webinar. But leaky gut is a condition where there is a breakdown of the lining of the gut. which means that if your gut is broken in multiple places, not only are you allowing undigested food to enter, but you are also allowing bacteria, fungi, you are allowing toxins to enter right inside your body. And when that happens, you are directly producing inflammation as a result of that. You will also get into trouble with nutritional deficiencies because your gut is not optimal in terms of its ability to absorb nutrients. A leaky gut directly causes increase in cortisol. Leaky gut can also affect thyroid balance. So all of these factors, we have talked about these factors as directly influencing all the other hormones. Then we talked about toxins. So xenoestrogens, when we are exposed to xenoestrogens or toxins, the toxins can directly cause leaky gut. And they can also cause inflammation. They can also cause nutritional deficiencies. They can also cause hormonal imbalance, both cortisol, thyroid, and through these, they can also influence the other hormones like estrogen, progesterone, prolactin, aldosterone, and testosterone. One other factor that we haven't talked about, which also plays a very important role, and unfortunately a lot of times it gets missed, is stress or trauma. If there is a history of trauma, whether in the childhood or the trauma is later on, you are going through a very difficult time, that trauma or that stress can directly cause inflammation, nutritional deficiency, cortisol, and thyroid imbalance. And so all three factors are factors which are not hormones, but they can have a significant impact on hormonal imbalance. I do see some people raising their hands, and I would request you to please go ahead and put down your questions in the chat box, and we will definitely get to them.
You mentioned toxins and xenoestrogens. What are xenoestrogens?
So xenoestrogens are basically chemicals which have estrogen-like effects. They're also called endocrine or hormone disruptors. What that means is that these actually function just like estrogen. They will work on the estrogen receptor. The problem is this, that when we have our natural estrogen is metabolized or destroyed by the body in a matter of a few days. But these chemicals, we cannot degrade them. So once they get on the receptor, they continue to produce their effects for a very long period of time, and they are not regulated by other hormones like our own hormones. And the result of this is major hormonal imbalance. Particularly, they lead to what is called estrogen dominance. And all the conditions that I talked to before, whether it be PCOS or whether it be endometriosis, all of those conditions are conditions where there is estrogen dominance. They also lead to a reduction in testosterone. And so the outcome of exposure to xenoestrogens is breast cancer, testicular cancer, prostate cancer. They can also directly cause thyroid disorders. They're implicated in endometriosis, fibrocystic breast disease, ovarian cysts, migraines. In men, they can cause large breasts. They definitely can lead to infertility. And they have also been implicated in neurological issues leading to behavior changes. So they have a lot of implications. And unfortunately, they're all around us. So they are present in plastics. Remember, when you order something from the restaurant, you get that black box in which you have your food, and then you put it in the microwave. So this plastic is xenoestrogen, and when you're going to heat it up, or when you have hot food in it, that xenoestrogen is going to leach into that food. When you talk about nail polish removers, when you look at detergents or fabric stain removers, perfumes, fragrances, lubrication that's used in condoms or contraceptive gels have xenoestrogens. Fumes from new carpets, flooring, fiberboard contain xenoestrogens. Dry cleaning products contain xenoestrogens. Gases from copiers and printers, pesticides, fungicides, herbicides, which are present on our fruits and vegetables, they're actually sprayed on them. Bleached feminine products contain xenoestrogens. Cosmetics, lipsticks, shampoos, conditioners, lotions, deodorants, we are surrounded by xenoestrogens. So when you're using a personal product, when you're using a product for cleaning, you really have to think about what are you using, what are you exposing yourself to. And one of the very important resource for that matter is EWG, which is Environmental Working Group, where you can get some guidance in terms of how to get stuff which is cleaner, which does not have xenoestrogens, which does not have chemicals which behave as xenoestrogens.
If if a woman has a hormone imbalance and she sees a conventional physician, what are the treatment options and why are these not optimal?
So if you go to a conventional physician or a GYN, your options are oral contraceptives, which are basically synthetic estrogens and often horse progesterones. The second option, which is a second line, called Lupron or Orlissa, and the third option is surgery. Now, clearly surgery is a very, very, very invasive option, and it has a lot of complications in addition to scarring and bleeding and infection. Remember that when we go in for surgery, even if you're going for a hysterectomy, a lot of women who go for hysterectomy will have significant reduction in their hormones because the ovaries get traumatized during the procedure. So these organs that we have in our body are there for a particular function, like the ovaries release estrogen, progesterone, testosterone, which are critically important for us. So I'm not sure if it's optimal to remove a part of our body unless it's really absolutely necessary. As far as Lupron and Orlissa are concerned, their primary goal is to reduce estrogen, progesterone, and testosterone. And if you remember, I have told you that estrogen, progesterone, and testosterone receptors are throughout the body. And we need them. We don't just need them for periods, but we also need them to protect our brain. We need them to protect our heart. We need them to protect our bones. So these options are really short-term options. If you want to use them for 3 months, 6 months, that's understandable. But you cannot use them for the rest of your life because you do need these hormones. Last but not least, the option which is most often used is oral contraceptive. And we have to understand that oral contraceptives are not without adverse effects. Unfortunately, these are prescribed so commonly that we often forget that these actually have consequences, which include increased risk of breast and cervical cancer. You can get blood clots in the leg, which we call DVT or deep venous thrombosis. You can have the clot in your brain leading to stroke. You can have clot in your lungs causing what is called pulmonary embolism, which is life-threatening in nature. You can have clot in the blood vessel of your heart causing heart attack. They can cause high blood pressure. They can cause liver tumors called hepatomas and liver cancer. They can cause gallstones. We also know that oral contraceptives increase the risk of autoimmune diseases. They also increase the risk of insulin resistance and diabetes. They lead to weight gain and obesity. We also know that OCPs in some women lead to headaches and migraines. They cause breast tenderness, vaginal discharge, mood changes, and reduction of libido. So if you want to use something like this for a short term, that's understandable. But if you're going to use them for long term, for a hormonal imbalance, then you need to rethink. You need to know why is it that you are having that hormonal imbalance, because if you take OCPs and it helps you with your hormonal imbalance related symptoms, but then it causes 5 other issues down the line, then it is not an optimal treatment. An optimal treatment is a treatment which resolves the issue without creating new issues. And that is what we need to do. Optimal treatment of hormonal imbalance requires you to understand why is that happening, and then remove that root cause so that you no longer have the symptoms for which you had to use oral contraceptives.
Now, I'm sure most women would not want to go for an invasive procedure like surgery, and they would prefer to avoid these serious side effects associated with oral contraceptives and or Lupron or Lissa. How does functional medicine approach this issue of hormone imbalance?
So when we look at something from a functional standpoint, then the most important question we ask, okay, if something is related to hormonal imbalance, then what is the hormonal imbalance? Is it cortisol? Is it thyroid? Is it prolactin? Is it estrogen? Is it progesterone? Is it testosterone? We also look at what is the degree of inflammation, because remember that these hormones are also being influenced by other factors like inflammation. We ask, is there a leaky gut? Is there a problem with the gut bacteria? And that is critically important, because remember that estrogen is excreted from the body through the gut. And if you have bacterial imbalance in your gut, it will not allow the estrogen to get excreted from the body. Clearly, you will get into what is called an estrogen dominant state. We ask whether this person is being exposed to xenoestrogens. We also talk about what kind of diet do we want this person to have, because the diet is going to affect inflammation directly, but it will also affect the gut bacteria directly. We also talk about physical activity. What kind of physical activity do we want for this person? Because physical activity, we know, has direct implications on hormone imbalance. There are a lot of Ayurvedic and Chinese herbals that can be helpful to balance hormones. In women who have issues with trauma, who have issues with stress, mind-body techniques are the key. If there is a trauma, if somebody has PTSD, we have to address that. You cannot not look at the real issue and just try to band-aid the situation by giving an oral contraceptive. You have to address the issue. Personalized nutrients, including intravenous support that Christine was referring to, is also another tool that we have to help these women. Infrared hypothermic therapy is another therapy that we have in our office, which does wonders for these women and helps them with the healing. We also use peptides, and peptides are actually very small group of amino acids that we use for healing purposes. Detox is going to be very important, especially for somebody who has been exposed to xenoestrogens. In 90 to 95% of women with hormonal imbalances, we have tools to help them achieve hormonal imbalance without using any kind of hormones. In 5 to 10% of them, when we have tried everything, and if things have helped but not to the degree that we want to, then we would use bioidentical hormones as a last resort. And I did not say hormones, I said bioidentical hormones. Hormones which look like the body's own hormones. They are not coming from outside, they're not synthetic, they're not coming from a horse. And when we do that, we always have an assessment before we provide any kind of hormone replacement. We have an assessment during, and we consistently assess the hormones to see if we really need to continue the hormone replacement.
Hormonal imbalances be prevented?
Yes, hormonal balances can definitely be prevented because we know what leads to hormonal imbalances. So we know that inflammation causes hormonal imbalance. So if we can prevent inflammation in the body, we know xenoestrogens cause hormonal imbalance. So if we avoid xenoestrogens, We know that stress or trauma can lead to hormonal imbalance. So if we know how to cope with the stress, if we are able to overcome the trauma, we can definitely prevent hormonal imbalance. If we prevent leaky gut, if we keep our gut functioning in the right manner, if we have balanced bacteria, we can prevent hormonal imbalance. And that should really be the goal, that we need to be preventive so that we don't get to a point where we actually develop hormonal imbalance and we have to use, band-aids for kind of dealing with that.
So I'd like to talk about our next webinar, which will be Saturday, September 19th at 4 p.m. What is the root cause of my irritable bowel syndrome? Registration is required and seats are limited. So we please do ask that you use the registration. The objectives that we will be covering will be: what is the connection between IBS and gut bacteria? What is the link between leaky gut and IBS? Can hormones cause IBS? And what is the role of nutrient deficiencies in IBS? Can liver dysfunction affect the digestive system? And can toxins impair the digestive tract? So tell us more about your bowel-associated symptoms. So we don't want to hear just about flatulation and burping and belching. We would like to hear also, do you have brain fog? Do you get headaches? Do you get rashes? All of these things can be linked to the gut. So if you have any of these symptoms, please submit any questions and any concerns to the email at theholistichealing.org. And we will go ahead and put that in for next webinar. So today, I'm going to go ahead and look at our other questions, so bear with me. So for our first one, what are your thoughts on bioidentical hormones? Are they necessary to alleviate menopausal symptoms of vaginal dryness, or can these symptoms be relieved by natural means alone?
As I have just mentioned, that 90 to 95% of all menopausal symptoms can be addressed without giving hormone replacement therapy. And my go-to would be the non-bioidentical replacement options as the first line, because of a couple of reasons. First of all, our body has immense ability to heal, which means that if there is a hormonal imbalance and if we fix that, then your body will be able to produce adequate estrogens that you would need to alleviate these symptoms. Second of all, let's suppose if you are put on bioidentical hormones, remember that the risk of bioidentical hormones progresses as the years progress from the time of your menopause. So even if you are on a bioidentical hormones, after about 10 years of menopause, your risk to benefit ratio reverses, meaning your risks are much higher than benefit. So why would you want to put yourself at risk if you have other means of achieving your goal? And so the best thing would be to try other means first. And if you cannot, then it would make sense to look at bioidentical hormones. And like I said, we only have to use it in literally 5 to 10% of cases. Most of the time, we are easily able to resolve the issue without using bioidentical hormones. And that is what I would opt for.
Okay, and then our next one. What are your thoughts on soy? Is it effective in alleviating menopausal symptoms such as vaginal dryness?
So remember that soy is a weak estrogen, which means that it has estrogenic effects. But I think that, when somebody says to me that I'm trying to use soy to basically alleviate my menopausal symptoms, what they're telling me is that they're saying that my menopausal symptoms are because of my low estrogen. Is it true? I don't know. It is not necessary that all menopausal symptoms are because of low estrogen. You could have low progesterone. What about that? So before you imply that you have low estrogen or low progesterone, you need to have some kind of data to back yourself up. The one thing you have to remember is that the body is very smart. When we enter menopause, it is a very wise decision by the body to close the reproductive department because we will not be using it. So why spend so much time, energy, and resources in that department? We only need a small amount of function right now to sustain our estrogen, progesterone, and testosterone after menopause. So that is taken over by the adrenal gland. So the women who have menopausal symptoms, particularly very severe menopausal symptoms, the reason for that is actually a problem with their adrenal gland, because the function of the ovary, the small function that is left is taken over by the adrenals. If you have non-functioning or poorly functioning adrenals, then you have a lot of menopausal symptoms. And so your goal should really be to optimize your state so the body's production of its hormones or the body's imbalanced hormones get into balance, rather than try and see if you can put in weak estrogens. Because, and that is precisely what I'm telling you, that do not make assumptions that it is all about not having estrogen. You have to have data before you can jump to that conclusion. And if you have low estrogen, then you have to ask, why do you have low estrogen? Because we have cells which are producing estrogen other than ovarian cells post-menopause. So why are those cells not able to produce the estrogen? And what can we do about that? And that would be my course of thinking. And that is what I would like to achieve, is to have the body produce its own estrogen rather than trying to put in soy to kind of enhance estrogen. So that would be my line of thinking.
So I'm going to go ahead and combine a few questions because they all have to do with xenoestrogens. So the first part is, what is the best way to detox from xenoestrogens / avoid them, as well as, so what are some ways to mitigate endocrine disruptors? And also, what is the best solution for optimum hormone levels in postmenopausal women to protect brain and bone density after detoxing and avoiding these xenoestrogens?
Okay, so the first question was with regards to xenoestrogen in terms of how to avoid xenoestrogens and or detox. So of course, avoidance is the best strategy. And the best way is to avoid all kinds of unnecessary chemicals that you're using, and to be absolutely clear about, what are you using on your skin, what are you using in your home. We actually have a panel that we use which actually helps us identify all the toxins that somebody could possibly have. Besides fungicides, all of that stuff. We often do that panel in women where we are suspecting a lot of xenoestrogen use. That's number one. So avoidance is the first thing. Let's suppose if you have xenoestrogens, detoxification. Detoxification of xenoestrogen is actually a process that we undertake. And it is not like, okay, everybody will have the same process. Because remember that xenoestrogens would require a functioning gut to be able to get out of your system. And so the most important thing is that the first thing we do is we look for leaky gut and we fix the leaky gut first. Then we look at the person's ability to detox. Because remember that detox requires a lot of nutrients. Detox requires your liver to be functioning well. Detox requires your kidneys to be functioning well. Detox requires your lymphatics to be functioning well. Detox requires your mitochondria to be functioning well. So until unless those things are optimized, undertaking a detox could actually be a disaster. Because if the body is not capable of handling the load of toxins that you're trying to remove from the body, then you will actually get into more trouble. So you'll do more harm than good. Our last webinar was on mercury, and I would recommend you to actually look at that webinar because we have discussed detoxification of mercury there. And that would give you some idea about the process of detoxification. So that would be that we actually have a process, we actually measure the toxins before, then we look at all the things that I've talked to you about, we optimize all of them, then we go through a process of detox, which varies from person to person. There is definitely IV support that's involved in it, because remember that it's a very heavy process on the body. You're actually trying to leach out things from inside the cells and get them out. So it's a process we definitely help our patients. We definitely support our patients during this process. And then we do a post-testing because we want to see what the result is. Have we actually achieved our outcome or not? And so that is how we actually do this process of detoxifications from xenoestrogen. The last question was, if xenoestrogen has been taken care of, what are the optimal levels of estrogen, progesterone, and testosterone? And I think this is a $1 million question, because the level for each individual is going to be different. Because let's suppose somebody is not having any cardiac issues or brain fog issues, and they have a slightly low progesterone. Am I going to fix it? No. What am I trying to fix? Am I trying to fix the patient, or am I trying to fix the number? I'm trying to fix the patient. So I don't care if the progesterone is a little low. That is working for this patient. He or she is doing really well. So it is not about a number. It is about you. Let's suppose if you have a progesterone which is low normal, but you are having symptoms that are low progesterone-like symptoms. Am I interested in giving you progesterone? Yes, I am. But you can say, well, but it's low normal, it's not low. Well, for you, it's low because you are proving it through your symptoms. So remember that you are not defined by a number. You are you. So when we look at the range, for example, you look at a range of progesterone, okay? The range of progesterone is between 50 and 52. Now, what is good for you? Is 15 your number, or is it 30 your number, or is it 52 your number? Which will be good for you? How will I know that? I will not know that by looking at your result. I will know that by looking at you and your symptoms. So that is how we determine what number would be your best number. I hope that makes sense.
It does, and I think it actually ties really well in with this question of what are the optimal levels for female hormones, estrogen, progesterone, and testosterone in postmenopausal women, and what is a healthy goal for these levels?
And that's precisely what I said, that the goals are going to be determined by the symptoms. And the numbers will be, if the numbers will be interpreted on the basis of the symptoms. If somebody is asymptomatic, meaning they have no symptoms, and one of the numbers is slightly low, am I going to treat it? No, I'm not going to treat it.
In reference to oral contraceptives, what would you quantify as short-term versus long-term? And also another question, which is on oral contraceptive, is I've been on oral contraceptives for over 10 years. I'm not having many side effects. Should I be concerned? They've been on for over 10 years for migraines.
So here is the issue. The issue is, there are two issues actually. The first issue is, let's suppose you have a hormonal imbalance. Maybe it's PCOS, okay? And you say, well, I'm taking oral contraceptives because my periods were irregular. Now they have become regular since I've been on PCOS. So what have you done? What you have done is you have given a good band-aid to yourself, which would prevent your periods from being irregular. But will that prevent you from having diabetes, cholesterol issues, blood pressure issues, and consequences which come with PCOS? No, because oral contraceptives cannot prevent all the other issues that are associated with PCOS. And that is why oral contraceptives as a response to hormonal imbalance is not optimal, because it neither reverses the condition nor it prevents the complications of the condition. So yeah, I mean, till the time you're trying to figure out what the problem is, you want to take it for short term, maybe 3 months, 6 months, I understand that. Maybe for a year, I understand that. But if you're going to take that forever to deal with your symptoms, then that's a problem, because you are not really addressing the problem. You are You are merely addressing a consequence of PCOS, but not the real issue. How long is long? So, see, there are a lot of people who use oral contraceptives, and they will often say that they don't have any side effects. And what they mean by that is they don't have any direct issues, like they don't have weight gain, or they don't have nausea, or they don't have any bowel issues, which is great. But remember that oral contraceptives have predispose you to cancers. They predispose you to autoimmune diseases. And so if the longer you're going to use them, the higher the probability that you will get in trouble with those. So until and unless you absolutely have no other options and you've tried everything and you've gone to somebody, and when I say gone to a physician, I'm talking about going to a functional physician who's actually looked at everything and figured out what the root cause is, I probably would not recommend that as a long-term solution. I would only recommend that as a last resort when everything has been looked at and nothing is working.
Can anemia be reversed?
Oh, absolutely. Anemia is not supposed to be a permanent condition. Anemia usually is a result of iron deficiency or zinc deficiency or B vitamin deficiency. And no matter what the deficiency is, that can be identified, that can be corrected. And no one should have to live for anemia throughout their life.
Why do I have fatty liver yet I do not drink?
So there are two types of fatty liver. One is a fatty liver which is associated with alcohol, but the more common form of fatty liver is what we call NASH, or non-alcoholic steatohepatitis, or non-alcoholic fatty liver would be an easier term. So fatty liver is a consequence of a lot of different factors. Fatty liver is a consequence of gut and microbiome or gut bacteria abnormalities. Fatty liver could be a consequence of toxins that you have been exposed to. Fatty liver can also be a consequence of metabolic abnormalities that you have. Fatty liver can be a consequence of inflammation. So there are many, many, many reasons that can lead to fatty liver. And the best thing that you can do is to find out what is the cause in your particular context. You address the cause. Once you start addressing the cause, you will be able to see that you will lose weight and you will lose that fat in the liver and you will stop the progression of the disease.
What have you observed for outcomes with patients with uterine fibroids? And is there any go-to supplements?
So I think this question is we often ask, like, what supplements for X, Y, and Z. And unfortunately, when we ask that question, what we are saying is we are again taking the same approach, which is the conventional approach that, okay, you have high blood pressure, you take this pill, or somebody will say, oh, you have high blood pressure, you take this supplement. The first question that you have to ask in functional medicine, it's not like that. It's not about give a Band-Aid. Now, this time the Band-Aid will be a supplement instead of a medication. But even when you have fibroid, the biggest question that you have to ask is why? Why is there a fibroid? What is the hormonal imbalance? And you have to fix you have to fix that hormonal imbalance. Once you're able to fix that hormonal imbalance after finding out the root cause of it, then automatically you will stop the growth of the fibroid. And then, of course, there are protocols that you can do in order to reduce the size of the fibroid as well. We do some Chinese protocols for that. But then again, that's a later thing. That's a secondary thing. The first thing is to stop the progression. And the way you're going to stop the progression is to find out why you got them to start off with.
So we have a lot of questions about testing methods. So I want to start with, what's the difference in hormone testing when you go into a conventional versus functional doctor? And when you are doing functional testing, Dr. Ali, what are your preferred methods for hormone testing, saliva testing, as well as toxin testing? Do you do urine samples?
So if you go to a conventional physician, most of the time they do not do a lot of hormone testing to start off with. The only exception would be thyroid, and even in case of thyroid, they only do a TSH Some endocrinologists would do a free T4 as well. When you go to a functional physician, hormone testing is a norm rather than an exception. And so we do all kinds of testing. We do salivary testing, we do urine testing, we do blood testing. It depends on what is it that we are looking at. You know, for example, we prefer salivary testing for cortisol, and we prefer blood testing for thyroid. And of course, you can actually use a conventional lab to do an elaborate thyroid function test, like we do TSH, we do FT3, FT4, reverse T3, iodine, thyroid antibodies. And then, of course, there are certain blood tests which you can do even through regular labs, which can look at some of the hormonal profiles like prolactin. You can do free testosterone, total testosterone, SHBG in the bloodstream as well. We use Genova for our hormone testing. Especially if you want to look at a screenshot, you can do that. You can also do urine testing, 24-hour urine testing for that. But remember that the type of testing that you will do, particularly for estrogen, progesterone, and testosterone, will be dependent on exactly what you're looking for. Which means that if you are giving somebody a hormone replacement, then the type of hormone replacement that you are giving will determine what kind of test you're going to do to be able to assess it. So all those factors are going to go into that. As far as the labs are concerned for toxin testing, we use GPL for our toxin testing, and we find that to be pretty good. We use a mycotoxin also from GPL labs, and that's been very, very, very helpful for us to identify mold issues.
Do you have any go-to herbs for hormone imbalance and PMS, and what role does curcumin have to play in balancing hormones?
So go-to herbs would be an answer that I don't think I can give, because it depends on what is the cause of your hormonal imbalance, right? The go-to herb that we will give you will be dependent on what is causing the hormonal imbalance. But curcumin has a very important role in inflammation, actually, irrespective of the source of inflammation. So if you have inflammation in the bowel, then curcumin can be helpful. If you have inflammation in the brain, curcumin will be helpful. If you have inflammation in your reproductive tissues, curcumin is going to be helpful, because curcumin is actually works at many, many, many different levels. At the level of the genes to kind of prevent inflammation. And it actually works in multiple pathways. If you are trying to address inflammation, then curcumin is really a good way to go. But again, the dosing is going to be different, and you need to know the dosing. You also need to know that curcumin is not necessarily the most bioavailable compound, and so you want to make sure that you're using something which is highly bioavailable.
What is the safest form of birth control for a young woman?
So a couple of things. Obviously, condoms, I would definitely start off with that. But then I would also say that if you have, so the most important thing is if you know your cycles are regular and you know when you ovulate, then that period of time you can do avoidance and then use condoms, you know, would be one of the things that I would recommend as a way of birth control.
I'm concerned about the side effects of tranexamic acid, TRANEXAMIC. But the serious side effects concern me. I've read extensively about using ginger. Do you have any thoughts about that?
So yeah, tranexamic acid does have a lot of side effects. It's often used in women who are having very, very heavy periods. There are a lot of other herbs that you can use. I'm not sure ginger would be one of them. Ginger can actually make your blood thinner. And so it will not necessarily work the way you want to work. So my suggestion would be is that you talk to somebody who's a functional physician to look at what kind of herbal combinations can you use, because not often one herb that is given, it's often a combination of herbs that is given in conditions when you are hemorrhaging a lot, especially if you have excessive bleeding issues. And actually, a lot of times we may not even need to do that if we can find out. A lot of times, once we find out what the issues are of inflammation, once you control the inflammation, you can automatically reduce the bleeding quite a bit, actually. So you may not even need to use herbals just to symptomatically control or reduce the amount of blood flow. on a monthly basis.
Can Gainstein be used in a 26-year-old female with problematic endometriosis? If so, what dose is enough? And also, she was told that she may have PCOS. There were no cysts found. She also has migraines, but they seem so. I guess I was she being told that she might have PCOS, but there were no cysts, and also can Gainstein be used?
So, I mean, she mentioned PCOS and there was a mention of migraine. I mean, as you can see, this is precisely what I was telling you, that when you have hormonal imbalance, it will not just affect your reproductive organs, it will affect other areas as well. And it's very clear that's what's going on. And not all PCOS women have to have a lot of follicles, so basically that's exactly why I said it's very difficult to diagnose these conditions, because even though classically PCOS means that you should have polycystic, meaning a lot of cysts on the ovaries, but that's not the case in all women. Nobody is a textbook case of PCOS, and nobody is a textbook case of endometriosis. Most women have multiple issues that actually are coming together. So there are probably two different diagnoses that may be happening at the same time, but none of them would be presenting in a classical fashion, which is what I think is the case that you are describing. Gainstein is basically a soy derivative. It's an isoflavone. And the problem is that, if you're using it in PCOS, your underlying assumption is that you don't have adequate estrogen, or that's why you're using it, or you're using it because you have too much estrogen and you want a weaker estrogen. I'm not sure if it is really going to be powerful enough to, it will not be powerful enough to really overturn your diagnosis of PCOS. Remember, I said to you that PCOS is, the theory right now is that from a functional standpoint, it's more of a metabolic disorder rather than a hormone disorder. So if it's the metabolic disorder which is affecting the hormones, then you should be addressing the metabolic side of things instead of addressing the hormone side of things, because the hormones are simply a byproduct of what the metabolic activities in the body are doing. So if you're trying to address PCOS, you should really work on the metabolic end of things rather than working on the hormonal end of things. And Gainstein is only working on the hormonal end of things. So think about it. So when you are thinking about a disorder, think about addressing the root cause of the problem rather than the symptoms that are merely a manifestation of the root cause. And that's how a functional approach would work, that you would not address the outcome, you would address the cause. And Gainstein is only going to, if it would, that's only affecting the outcome. It's not really addressing the reason for why you are having hormonal imbalance.
Does Gainstein increase risk of clots? Okay. Is the estrogen patch dangerous?
So I think it's almost like you asking the question, is knife dangerous? Well, a knife can be dangerous if you try to kill somebody with it, but it is not dangerous if you try to cut the fruit with it. So it's not about if estrogen patches ranges. The question is, what is in that estrogen patch? Remember that there's estradiol, there's estrone, there are estriol. There are 3 different forms of estrogen. What form of estrogen is in that patch? How frequently is the person getting estrogen? What is the reason that person is getting the estrogen? So unless you have answers to those questions, you cannot really say, is it bad or is it good? You really need to have a better understanding of what are you being given, why are you being given, and what alternates are there which could help you with the situation, and use the patch as a last resort.
Okay. How do you feel about seed cycling to balance hormones?
Can you define seed cycling?
So seed cycling, I actually do seed cycling, and so I can kind of speak to that a little bit, but like basically eating during your follicular phase, eating a type of seed. I think they usually eat like sunflower seeds during your luteal phase and your pumpkin seeds. So they eat like sesame seeds, flax seeds during your follicular phase. You increase.
Yes, so I see what you're trying to do. So basically, the concept of seed cycling is very, you can say it's very fascinating. But as far as clinical outcome is concerned, like in my practice, we have never had to have somebody do seed cycling per se to control their symptoms. They might feel better if they do seed cycling. It may enhance the effect of what we are doing, and that's great, but the impact is not going to be huge. It's a small amount of impact. If it works for you, you can go ahead and do that. But I have never actually had to prescribe anybody seed cycling because I haven't found it to make it may make maybe a few % difference, but it's not really a major difference.
Is there a endo diet or a specific anti-inflammation diet?
No, there is no endo and or anti-inflammation diet. Remember that we are all different. So for example, if you have sensitivity to broccoli, broccoli is a really good vegetable. But you could be sensitive to broccoli, and so in your case, we may have to remove broccoli. But you can argue that broccoli is anti-inflammatory. Yeah, it is anti-inflammatory, but in your case, it is not, because your body reacts to broccoli. And so when you are looking at an anti-inflammatory diet, yes, we know that certain foods are highly inflammatory. And for example, sugar is highly inflammatory. So everybody should avoid sugar. I mean, that goes without saying. Everybody should avoid fast food. But when you're talking about a diet, when you're talking about what vegetables and what fruits you should eat and what kind of proteins you should eat, that is a discussion which requires a much better understanding of your biology. What I mean by that is we need to know what kind of problems are being manifested. Even if it's hormonal imbalance, we need to know what is the root cause. Is it really a problem with blood sugar regulation, or is it a problem with blood cholesterol regulation, or is it a problem of having inadequate anti-inflammatory or antioxidants? So depending on what your problem is, then we have to come up with a diet for you, and which will be a very different diet for another person with the same diagnosis. Because they may have a different gut problem, you may have a different gut problem, they may have a different malabsorption issue, you may have a different malabsorption issue, they may have been exposed to a different toxin, you have been exposed to a different toxin. So until unless we really understand your biology, your physiology, it is very difficult for a physician to actually just give one diet. No one diet is going to fit everybody. That is never going to happen. You need to know what diet will work for you. And that is why we always get data. We never prescribe a diet until and unless we know what's going on inside your system.
What if someone's period has stopped and they are not pregnant? What hormones are off balance, and what might help bring your period back? And the other one is, on that same respect, is what if a young woman's period stops for years? What side effects can occur with the body? So how do you bring the period back? And if it does stop for years, what side effects?
So basically there are two types of loss of period. One is called primary amenorrhea, which is you never have a period. And the second one is secondary amenorrhea, which is when you were having period and then you actually had your period stopped. So how are you able to get the period back? So the first question is, why does the woman not have periods? There are multiple reasons why a woman could stop the period. One of the very common ones is inadequate nutrient is one of the causes. The second one is, there is some major hormonal imbalance that's going on, which is causing her to have this problem. The third one is it could be structural. When someone has scarring in their uterus, that can also cause not having any period. So there could be structural issues and there could be functional issues. So if it's a structural issue, then it doesn't matter what supplement you put in it, it's not going to resolve the issue. So the first question would be, and actually this is another thing that we have seen in women who have been on oral contraceptives for a long period of time, after stopping oral contraceptives, they may never get a period. And we have actually seen that in our practice. So you really have to understand, what is going on in terms of why that period has stopped. And depending on that, you can give a supplement or a support to that woman. We especially do intravenous support with phosphatidylcholine, which can be very helpful for these women, provided it's a functional issue and provided it's a nutritional issue. As far as the side effect is concerned, so remember that it is very important if you have an ovulation because, or you have amenorrhea because you are not ovulating, meaning that you're not having a regular cycle. It could be because you may have deficiencies of certain hormones. And if you have deficiencies of certain hormones, they have direct implications to your heart, to your brain, to your liver. So it has direct implications to your hair, to your skin, so on and so forth. So the implications of not having a period are going to be related to what hormonal issues are there to start off with. And so it will depend on that.
Do you use test hormones via, do you test hormones via serum or urine on particular days, like day 3 for estradiol and day 21 for progesterone? Are there panels for
so if you're having menstruation, then we will tell you exactly when you would like your hormones to be tested. And I'm talking about serum testing. If you're going to do urine testing, then I would do a 24-hour urine. But we do use serum testing, especially if you do at the right time. You can get a pretty good screenshot of what's going on. And it's much less painful than doing a 24-hour collection of urine.
Many teens and young women are taking over-the-counter OCPs for 3 to 6 months without allowing a cycle to occur. Is this bad long-term?
Definitely. I would not recommend using OCPs where you don't have a period at all. I'd rather have an OCP where you actually see that you are having a period and there's some kind of a cyclical change that you see. Of course, you have to have the use of OCPs to not have periods for months and months and months. At least that means there is no break to the system. When you get a oral contraceptive pill, what happens is that you take it for about 21 days and then you have no hormones for 4 or 5 days. That's when you actually see the flow happening, And when you take it for 3-4 months, it means you're constantly building up the system or you're constantly blocking the system. It's never without hormonal influence. So I prefer to have a pill which would give you a flow and which would give you a break from the hormones rather than a pill which kind of shuts you off completely for 3 to 6 months. If I have to choose, clearly I wouldn't want a pill to start off with, but if you have no options, that's what I would prefer.
Can you kindly afford strategies to minimize excess hot flashes?
Well, the question is, why do you have hot flashes? Is it because you have adrenal issues? Are you having hot flashes because you have a problem with one of the hormones which is low? For example, do you have low progesterone? Is that why you're having hot flashes? Are you having hot flashes because you have a thyroid issue? Are you having hot flashes because you're having a ton of inflammation from the gut? So depending on your cause of hot flashes, you need to be treated. There is no one pill that we give to hot flashes. In some patients, once you treat their gut, their hot flashes stop. In other patients, when you control the cortisol, if cortisol is the problem, then their hot flashes stop. So once you know the root cause, then you address the root cause. It's not like taking a pill. So here is the issue. Even if you are given a supplement, let's suppose somebody gives you a really amazing supplement that stops your hot flashes. Remember, that's still a Band-Aid. The important question that you have to ask is that that supplement may have stopped hot flashes, but it may not affect the other implications that are happening because of the root cause. So for example, if it was cortisol which was causing the hot flash and you were able to address the cortisol because that supplement addressed the root cause, your hot flashes stop, which means that the impact of cortisol on your hormonal system was offset. But what about the impact of cortisol on your other organs like your brain, your gut? All of that is still ongoing. So it is very important. That is the reason why it is not enough to Band-Aid with a supplement, because the root cause continues to have its impact on other organs. That is why it's important to identify the root cause, and that's why it's important to address the root cause rather than merely taking a supplement for Band-Aiding the situation.
If you must be on oral contraceptive, is it better to take the birth control pill in the morning or at night, or does it matter?
See, the most important thing about a birth control pill is that the birth control pill should be taken on a regular basis. If you think that if you use it in the morning and you'll continue to be able to do that, that's great. If you think if you do it in the morning you'll forget, then I would rather take it at a time where you can actually remember it. That is more important for a birth control, because if you're going to forget it, then you're going to have an issue with, because you've now created a big breach in the hormonal cycle the way it's supposed to be. So my suggestion would be, instead of trying to use it in one morning or evening, use it when you can actually take it. Regularity and consistency is more important if you are on a birth control pill than anything else.
How do I lose weight if I have insulin resistance?
So if you have insulin resistance is a product of inflammation. Insulin resistance is a product of some toxin, or insulin resistance is a product of bad bacteria or fungus in your gut. So it is not impossible. Like, I see a lot of women who are frustrated because they have gained a lot of weight and they want to lose weight. And I have to tell them that, believe me, if you can understand the reason for your insulin resistance, and if you address that, then there is no reason why you cannot reverse that weight loss. You will be able to reverse that weight loss once you identify the cause of insulin resistance. It's not rocket science.
Is salivary testing the most accurate way to check for hormones?
No, it depends on what hormone you're looking for. We usually just use cortisol when it comes to salivary testing.
Are you checking cortisol in the morning, or does time matter or not?
Time matters a lot. Time matters a lot. And when we check cortisol, we check for 4 points in a day, not one-time cortisol. If you go to a conventional endocrinologist, they might sometimes check cortisol. They check first. They check AM cortisol or morning cortisol, but that's not how we work. The blood cortisol is really worthless unless you're looking for a tumor that's releasing a lot of cortisol. The cortisol that is checked in the functional testing, we're not looking for a tumor. We're actually looking at how is the cortisol curve throughout the day. And for that, we need 4 points of cortisol and saliva.
Can Avmacol help detox from xenoestrogens? AVMACOL. Avmacol. AV. A is an apple. V is in violin. MACOL.
MACOL. Avmacol.
Yes.
So I am not sure what Avmacol is, to be honest with you. This is
they just said it's broccoli sprouts activated with.
Oh, I see sulforaphanes. I think you're talking about sulforaphanes.
Yes.
Sulforaphanes are actually a product that's present in broccoli, and you're talking about detoxing xenoestrogens?
Yes.
So you have to understand that sulforaphanes have actually usually been used for balancing estrogen metabolites. So remember that estrogen metabolites, 4-hydroxyestrogen, 16-hydroxyestrogen are the metabolites of estrogen, which actually determine if you're at high risk for breast cancer, ovarian cancer, etc., etc. And sulforaphanes are often used for balancing metabolites. Sulforaphanes are not for xenoestrogens. Xenoestrogens is a very different ballgame. They are what we call not necessarily highly degradable. And so the way you will get rid of xenoestrogen is going to be more through a chelation protocol rather than using something like sulforaphane. And that's why I said if you go to the Mercury webinar, we had talked about the chelation protocol, and that would give you some idea.
What about yarrow for heavy menses?
So yarrow is used for heavy menses, but yarrow is not used alone. Usually it's given in a combination of 2 or 3 other herbs that you give for heavy bleeding. But like I said, that you want to understand that yarrow and the other herbs that are often given have to be monitored very closely. And remember, that's still a Band-Aid. It's a Band-Aid. It's a Band-Aid for heavy bleeding, but it does not necessarily address the reason for the heavy bleeding.
And our last question is, I see a lot of premature ovarian failure post long-term use of birth control pills. Is this typical? How often does this happen?
So again, it's not about whether it's typical or not. It definitely happens. We have seen it for sure. And it's very hard to predict. This is one of the problems. When people say, I don't have any issues with birth control, you won't know till you have premature ovarian failure. And premature ovarian failure has a lot of problems because remember, premature ovarian failure means that your ovary is not releasing estrogen, progesterone the way it's supposed to very early in time, which means that you are predisposed to osteoporosis, you're predisposed to heart disease, you're predisposed to Alzheimer's disease, you're predisposed to issues with your skin, issues with your hair, issues with anemia, issues with your gut, autoimmune diseases. So that is precisely something that can definitely happen. I don't think I have the numbers in terms of what percentage of people it happens, but even if it happens in 5% of people, let's suppose, we don't know if you will be in the 5% or not. So when you are going to be on birth control pills, you are taking that risk, and you should be aware of that.
Thank you so much. So that concludes today's questions and today's webinars. And as I promised, here are 2 resources. As I was talking before, the Endo What initiative for school nurses and for yourself to introduce the topic and raise endo awareness to when it actually starts rather than when infertility hits. And then PMDD, which is IAPMD. They have volunteers who work. I'm actually a volunteer there, but they have it to, if anybody's having suicidal ideations, you can go on it, and they have folks who actually are there live that meet and they'll chat with you. And it's cool because it's not just like suicide hotline where you call. They actually will keep tabs, and so when you come back, they'll bring up your case, and they'll actually keep track of it, so you don't have to repeat yourself and go through a lot of the thing. They also have tons of resources for doctors as well as patients and awareness. So thank you so much.
Thank you, everybody. Bye-bye.